Good evening, everyone, and welcome to our second masterclass on total joint replacement for the lumbar spine. This is a new procedure currently in U.S. clinical studies, which is being sponsored by 3Spine. My name is Robin Young. I'm the CEO of RRY Publications, and I will be your moderator tonight. Let me take a moment to acknowledge the incredible turnout we had for our previous masterclass last February, where we introduced the concept of lumbar total joint replacement. The overwhelming response that we received was truly gratifying and a testament to the innovative and dynamic landscape of the spine industry. If you haven't watched our first masterclass on lumbar total joint replacement, I encourage you to do so. A link to the full recording is on our website, ryortho.com. So tonight, we're going to hear from 5 surgeons who are participating, in fact, they're investigators, in 3Spine's clinical studies. Dr. Jeff Goldstein will lead us off tonight. Because the 3Spine IDE study is an ongoing work, Dr. Goldstein will moderate much of this program in large respect to help us get it right. Dr. Goldstein serves as the National Principal Investigator for the MODUS Lumbar Total Joint Replacement IDE study. He is Director of Education and Director of the Spine's Fellowship Program at NYU Langone Orthopedic Hospital, as well as Clinical Professor of Orthopedic Surgery and Neurosurgery at NYU's Grossman School of Medicine. We will then hear from Dr. Alex Salaticky, followed by Dr. Ben Gettys, then Dr. Anton Jorgensen, and finally, Dr. Sivaganasan from Thomas Jefferson will wrap it all up at the end. Dr. Sivaganasan, who I'll introduce first, even though he is wrapping things up, is a neurosurgeon and assistant professor of neurological surgery at Thomas Jefferson University. He completed his fellowship at the Hospital for Special Surgery after completing a residency with Dr. Clint Devon at Vanderbilt. You'll hear more about his background during his talk. Dr. Alex Salaticky, who will lead us off this evening, is a board-certified orthopedic spine surgeon at SOCI at Steamboat Springs, Colorado, and he specializes in motion preservation for the neck and lumbar spine. He completed his fellowship at New York Presbyterian Columbia University Medical Center, and he also completed a residency with Dr. Devon at Vanderbilt. Our second speaker is Dr. Benjamin Gettys. He's a fellowship-trained orthopedic spine surgeon who practices in Chattanooga, and he specializes in the treatment of all spine conditions, both adult and pediatric. He earned his medical degree from Emory University School of Medicine and completed an orthopedic surgery residency program at Yale University, followed by a spine fellowship at the Leatherman. And finally, just before we go to Dr. Sivaganasan, will be Anton Jorgensen, who is a former Goddard Space Flight Center aerospace engineer, now board-certified orthopedic spine surgeon who completed a fellowship at Rush University Medical Center. He served as the chief of orthopedic spine surgery at Brooke Army Medical Center for 5 years and had served overseas in 2 deployments to Afghanistan and Qatar. Well, we have a lot to cover tonight. So without further ado, I'd like to turn the floor over to my good friend, Dr. Jeff Goldstein, and he will conduct the master class tonight. Dr. Goldstein, the floor is yours.
Thank you, Robin, for that really very kind introduction. What I'd like to do tonight is introduce our study design for our viewers. This is really 2 studies that we're running concurrently. The first is a real-world analysis. We're evaluating patients who have undergone spinal fusion, specifically TLIFs. And at each site, once they finish that block of patients, then they can move on to our investigational device, which is the MODUS. Now, throughout tonight's talk, you may hear the MODUS referred to as the balance back or the MODUS, and the name has really transitioned over time, so please don't get confused by that, but we're really moving towards the MODUS because this is a motion device, and that's what MODUS implies. So it's a very traditional study design. It's a multi-center trial with 20 investigational sites. It's prospective, non-blinded, and non-randomized. And there's serial enrollment in each site. And this really eliminates a couple things. It eliminates, number one, crossover, but also ethical challenges. Some of you may remember when we did the artificial disc replacement trials for the lumbar spine, patients really didn't know until they woke up from surgery whether they had an artificial disc or they had a spinal fusion, and that created challenges by themselves. It's propensity score matching, and that's used to balance between the groups through subclassification. Another really important point that I'd like to bring out to everyone is that there are no training cases allowed. All of the surgeons went to Memphis and they spent time learning the procedure, and but all of the cases count, and you'll see the data from all of the cases. And there's about 150 investigational subjects. So once again, the key design elements are it's a real world analysis, an adaptive design using propensity score matching, which has really been used in a lot of the most recent spinal trials. Let me stop there, clear my throat. The precedent for the adaptive design and propensity score matching, as I said, has really become popular and is a standard for trials. You've seen a Bayesian adaptive design in these three studies for the Vertiflex, the Coflex, and Barricade. And propensity score matching was used in three of the most recent cervical artificial disc replacement trials, including the simplified 1 and 2 level trials. All in all, we'll have about 300 patients, 150 patients in each group, the investigational group and the control group. Like the more recent studies looking at motion preservation, we're looking at 4 primary endpoints. And this is a composite clinical success that's determined at 24 months post-op. And the 4 things that we're looking at are no SSI, including revision, reoperation, removal, or supplemental fixation at the index level. We also want to see that there's an absence of serious device-related adverse events and maintenance or improvement in the neurologic status compared to baseline. And by improvement, we'd like to see at least 15 points of ODI, and that's out of 100 compared to the baseline. In addition, we're going to look at several secondary endpoints, including VAS back and leg pain improvements, the mean change in ODI over very specific time intervals. We'll look at also the mean change in leg and back VAS over time intervals. And very importantly, we want to make sure that there is no significant subsidence in the device. And finally, we'll look at several other endpoints, and we really want to, slice and dice the data the best we can, and try to figure out which patients are best for this device. We'll look at demographics, and that'll include the patient's age and also the BMI, comorbidities, whether they've had prior fusion procedures, prior lumbar spine surgery. And is this device best for patients with early stage disease or patients with late stage disease? And so we'll also look at patients who have more than 75% disc space collapse. So at this point, what I'd like to do is turn this over to 3 of our investigators. So we have 3 investigators who have completed their enrollment. And at this point, I tell them that they're really the world experts. And I've asked them to put together 3 cases for me. The first is I want them to show us where they are now as a total joint replacement surgeon of the lumbar spine. Where are they now after they've completed it? And what have they achieved? But then I also want to see an average case, a study that represents maybe the vast majority of the cases that you did throughout the trial, and then a case that we can all learn from, maybe a more challenging case that was challenging for you, and maybe you can bring home some key points that we can keep in mind as we do our own patients. So at this point, I'd like to turn this over to Dr. Salaticky, and Alex, go ahead and show us what you've learned from this study.
All right. Thank you very much, Jeff, for the introduction. Thanks for moderating this event. I've been very blessed and fortunate to be a part of this study, which I think is going to be quite a good change for the world of spine surgery and a great change for our patients as we look for better alternatives to fusion surgery. So as Jeff mentioned, I'm Alex Salaticky. I practice in Steamboat Springs, Colorado, and I'll go through my three cases I've selected from this study. I started with what I think is one of my best cases, lead with your strong foot, I guess. And so this was one of my later patients, I believe number 18 out of the 20 that I did. So after having gone through some of that learning curve, really felt good about this operation and had a good result. So this patient came to me as a 43-year-old female, mother of 4 younger children, so a very active lifestyle, active lady who had a really bad problem at L5S1. She had a prior microdiscectomy about 1 year before she saw me and did well after that for about 9 months, and then had a recurrence of her disc herniation. And so she went back to her prior surgeon and showed this MRI. Shows a very large central disc extrusion, complete disruption of the longitudinal ligament, pretty severe stenosis in the spinal canal. And so she was recommended to have a fusion surgery, which I think is a very reasonable approach for somebody like this with this large of a disc herniation after a prior decompression. She ultimately came to me asking to look at enrollment in this trial, and we registered her for that and enrolled her. So it was roughly a year after her original microdiscectomy. Surprisingly, this patient had mostly back pain and radiculopathy, did not have any cauda equina type symptoms, aside from some complaints subjectively of some bladder irritation, feeling of urinary frequency, but not anything that was a true emergency, fortunately. We took her to surgery and performed the modus reconstruction using the posterior approach as described in the technique guide. So this is her post-op x-rays, L5S1 joint replacement done. And a couple of things I point out here that I learned through the course of doing these is really trying to get good symmetry each side, preparing the end plates with the oscillating rasps and get these implants to line up really well, not just in terms of convergence of the implant, but also depth. You don't want necessarily one implant deeper into the disc space than another. That would compromise some of your flexion and extension. So on this x-ray here, the AP view, I think in terms of what we're trying to achieve, this is pretty close to what we would see as an ideal AP view. The implants are symmetric, they're converged along the axis of the pedicle to prevent some of that anterior translation, using that kind of snow plow effect, to use a skiing analogy from Colorado here. Her standing lateral view shows good overall lumbar lordosis, good sagittal balance with the implant. When her standing in a neutral position, the implant sits in essentially a neutral position, which is what you really want to see. And then as the patient sits and flexes forward, that implant allows the L5S1 segment to go into flexion and allows the rest of the spine to go into flexion and maintain that mobility, which is really the key difference between this and a fusion operation. We're maintaining that lumbar motion, not putting strain on the adjacent segment. So you see the patient's outcomes. We have 3 months of follow-up on her, and you'll notice over on the right-hand side, ODI score dropped from 50 down to 12 by 3 months. Her leg pain, which predominantly was on the left side before surgery, went from 63 to 0. And back pain went from 25 to 5. She has reported a little bit of irritation in the right leg immediately post-op, but that has all been resolving as well. The patient's been ecstatic with how well she's done. She's very happy with her result to the 3-month point. And I anticipate, based on the good x-ray results that we have and the early results that we have, that she should continue to improve and do well over the course of her follow-up. Another case of mine was a little bit more of a challenge, but still, I think, a good example of one of the benefits of this operation, of this reconstruction. This patient was a 71-year-old gentleman, still very active, works as a massage therapist, but also a recreational pilot and a farmer. So he's engaged in a lot of different activities, but has been limited for much of his life by back pain with some chronic radiculopathy. He reported to me 35 years of ongoing back pain, intermittently radiating down the right leg, which had become worse over the last 5 to 10 years. And he had undergone many treatments for this, numerous epidural steroid injections, physical therapy, chiropractic adjustments, multiple treatments that were not necessarily consider traditional acupuncture, herbal medicines, herbal supplementation. He was really sort of scouring the globe for various ways that he could treat his back problem without having a fusion operation. He did end up having two foraminotomy procedures, which were done several years before he and I met. And those procedures never really did give him much in the way of relief. He reported perhaps 6 months or so of relief of some of the radiculopathy with the first operation. The second foraminotomy procedure never allowed him very much benefit at all. And so he came to me seeking treatment, hoping to enroll in the 3-spine study. So his x-rays here show not an overall great looking spine, not terrible, but certainly there's multiple levels of abnormality seen on the x-ray. There's just a little bit of coronal plane tilting at L4, L5. Obviously L4, L5 disc degeneration with height loss there, no real instability on seated flexion x-rays. He did have also some degeneration up in the upper lumbar spine. And I'll click through to his MRI. So again, notes to make on this one: multiple level lumbar disc disease, which we all see very commonly in our practice in patients in their 60s and 70s. He has some mild disc degeneration at the L5S1 level without any appreciable stenosis. L4, L5 disc degeneration. And the most significant finding really was this right-sided subarticular recess stenosis, also foraminal stenosis, some facet disease. You can see on this axial view that L5 nerve on that right side maybe being caught by some of these little facet spurs coming off that joint. Centrally, no real stenosis, and the left side neuroforamen was open. Disc degeneration at the upper lumbar spine, but otherwise no real stenosis at those levels. So here are this patient's postoperative x-rays. Overall, not bad. I'll critique myself here a little bit. On the AP view, that right-sided implant, a little bit more medialized than the left-sided implant, and the upper end plate of that implant is rolled in just slightly, indicating that the keel cuts may have not been perfectly aligned in the same axis. The lateral view looks good. The implant center of rotation is sitting right about at that 40-yard line from the back of the vertebral body to the front, right where that center of rotation lies. And the seated lateral view does show the implant flexes well, moves as he sits in flexion. We see the tails of the implant offset a little bit. I think there is some obliquity to that x-ray as the patient was sitting. And so they don't always line up perfectly en face like that you see in the middle picture. But this patient did actually end up having quite a happy result. He's still on his way to improving, not 100%, but he's certainly much better than he was. Back pain scores pre-op 97, by 3 months was down to 13. His right leg, that chronic radiculopathy that really had been driving him crazy, that he'd been chasing for so many years, is finally on the mend, and he's very happy about that. His pre-op leg pain VAS score was 100, post-op is 17. Left leg was always relatively inconsequential and remains that post-operatively. And his ODI score, you see, goes from 62 down to 16. So, really ODI below 20, we consider that an effective cure of a lumbar problem in terms of what their disability is for their low back. And then I'll finish up with this case, which is a great teaching case for me. A bit of a challenge, ended up with a nice result, but I think for me, it really demonstrates how this implant can serve to be a true alternative to fusion, maybe beyond some of the other motion preserving technology. So this patient is a 74-year-old female, roughly 3 years, probably a little more, of low back pain with worsening radiculopathy, primarily affecting her left leg. You see on her x-rays here, she does have a dynamic grade 1 spondylolisthesis and associated disc degeneration at that level, as well as some disc degeneration at the level above, L3-4. One thing that's important to notice, her standing lateral view, you can see a subtle grade 1 slip at L4, L5. When she sits in the lateral position, but is still upright, that slip accentuates a little bit. But when she sits and slumps forward, you really see accentuation of that listhesis. So that slumped seated view really helps to uncover otherwise hidden instability. Here are her x-rays. So Primary level of pathology is L4, L5. Again, the grade 1 spondylolisthesis you see on the far right axial view, severe facet hypertrophy with severe central and recess stenosis bilaterally. The other thing I pointed out in this case is she does have disc degeneration at L3, L4. You see that on the sagittal view. This is the axial at L3, 4. Not terrible, but there is certainly some left-sided facet pathology, left-sided subarticular recess stenosis, and the patient's primary symptoms are left-sided. L5 distribution, but that's not always clear-cut and always to delineate whether it's pure L4 or L5, especially in somebody like this. The other thing I'll point out is her L5S1 disc has some degeneration as well. So leading up to this point, this patient in many surgeons' hands, my own included, would be a good candidate for a lumbar fusion procedure. And in my hands, mostly this is a posterior-based operation, doing a direct decompression of those facet joints and doing a T-lift procedure. The problem with a T-lift in her case is, as we all know, adjacent level degeneration. She already has some breakdown at L5S1 without stenosis there. She's got a little bit of breakdown at L3, 4 with some early stenosis. So fusing an isolated L4, L5 level, likely she'll be back for another fusion within a few years. You then consider, okay, doing an L3 to L5 fusion. Again, the same fate can come to S1, and doing an L3 to S1 or even pelvis fusion in the 71-year-old lady, it becomes quite a big operation to recover from. So having an alternative joint reconstruction option like this that allows us to do a full decompression, open up the recesses, open up the neuroframe, and reconstruct that segment without putting strain on those other segments, I think is really a game changer, and something that's quite unique to this implant. Allows for that posterior complete decompression. In addition, with this operation, you can do a little bit of decompression at the level above. So in this case, I did a complete laminectomy of L4. You take off bilateral facets as part of the procedure, and then at the level above, you can also do a little bit of subarticular decompression, taking out some of that subarticular stenosis with the Jorgensen reaching up under to decompress that traversing L4 nerve root. So this patient had the L4, L5 procedure. AP views, really happy with how those implants converge. One of the things I learned in this case as well with a spondylolisthesis like this is the tendency for these patients is to have anterior translation of that L4 vertebral body, and we need to try and resist that. So the best way to do that with the design of this implant is by converging the implants along the axis of the pedicle. But in cases like this, you even can go beyond that. So starting out a little bit lateral to the pedicle as you're coming in the dorsal side of it, and you come almost across the pedicle, making sure that when you reach that pedicle body junction, you still have the implant resting on that, but allows for a little bit more convergence of the implants so that you resist that anterior translation post-operatively. So you can see under standing lateral views, upright lateral view, she has great alignment, great lordosis at that level. So good sagittal plane balance, as would be any critique for any fusion surgery you want to achieve that. The key here is that if you look at her slumped sitting x-ray all the way on the right, she really moves quite a lot through that implant into flexion, and that allows for, again, that dynamic stability that we see using these implants. So upright standing, she looks great in sagittal balance. With seated flexion, this allows her L4, L5 segment to go into flexion and avoid straining those other discs. This is a great teaching case for me, again, because it demonstrates how we can treat a spondylolisthesis case with a motion preserving technology like this. It doesn't require fusion. You can really do a full posterior decompression, and you can also treat a patient who we would call maybe the 1.5 levels of degeneration, where her primary pathology is at L4, L5, but she has some early degeneration at the next level, and you'd be debating with yourself whether you need to include those levels with fusion. In this case, I think demonstrates that you can treat just the index level or the pain generating level, and you don't necessarily have to do a bigger operation to prevent early degeneration adjacent to your fusion. This patient was one of my rock star results. This was not everybody, but certainly one of the great results we've seen. So by 3 months, zeros across the board, 0 back pain, 0 leg pain, ODI from 56 to 0. Really came out of the gate flying and is doing very well. I look forward to seeing her back at 6 months. Maybe she'll bring me cookies or something, I don't know, but she's very happy so far.
Thanks, Alex. I really appreciate it. And I appreciate the introduction by Dr. Goldstein. My name is Ben Gettys, and I'm an orthopedic spine surgeon in Chattanooga with a private group called Center for Sports Medicine and Orthopedics. I'm going to get into some of my cases, some good, bad, and the ugly. But before I do that, I just wanted to take a minute just to sort of acknowledge why someone in private practice like me would be interested in being a part of a study like this. And for me, I think if, in my own practice and in training, you see that if you have a well-indicated patient and a well-performed surgery, that fusion can have a really good short-term outcome. But, we also know the downsides to fusion, which would be, lack of motion, obviously, and then adjacent level disease, which we all know is significant. And so if there's something that could achieve the goals of stability and decompression, but allow for motion and hopefully decrease or maybe even negate adjacent level disease, and that's clearly the holy grail of spine surgery. And I think it's worth sort of tirelessly searching for that. And I think this study is a step towards that. And so that's why I think it's important for me, but for all surgeons that are interested in, furthering spine care. But beyond that, let's get into some cases here. So this is my first case that I'd like to present. And just like Alex said, this is sort of an ideal candidate. We'll start with that, and then we'll go through a couple other cases. But this is a 36-year-old male that came to my office, and he had this, recurrent back pain, this perfect story for degenerative disc disease that's really been plaguing him for a better part of a decade or more, where he'd have a flare up, his back would go out, it would take him a couple weeks to get over it. There frequently be transient radiculopathy associated with it, back pain, obviously. And if you saw him on the street, you'd never expect it. Very fit, very active, very successful young man. And this would just lay him up. And so he's obviously gone through the gambit of physical therapy, personal trainers, all the conservative modalities you can imagine. And then in addition to that, all the interventional modalities, including injections and things of that nature. And I really was on the lookout for a more definitive fix that wasn't fusion-based. And you can see here on the x-rays, even without an MRI image, which obviously would show modic changes and those sorts of things that we're used to seeing, you can see on the lateral view in particular that there's already some collapse and some of that scalloping of the end plates, just that degenerative look to it. Not spondy, no instability, but just starting to collapse and wear out. And some foraminal stenosis, which is why you get some of the transient radiculopathy as well associated with it. 4.5, 3.4 look relatively normal in him, both radiographically and on an MRI as well. And again, there's no instability in this patient. So we elected to proceed with an L5S1 bounce back procedure. And here you can see, I mean, this is a great example. Again, this is one of the idealized situations, but to Alex's point, you can see the implants are well converged on AP view. Just like with any arthroplasty, sometimes we get into a situation where you're kind of between sizes. This size really fit him perfectly in terms of end plate coverage, but also just getting that center of rotation, as Alex mentioned, right where you want it. And this is soon after surgery, and you can already see his global spine moving. Now, I think what I learned from this patient is, in particular, folks that have a pretty mobile spine, with the exception of one level, they're young, they're active, really mobilizing the remainder of the lumbar spine is faster than in some folks that have been guarding and locking down and having a stiffer spine over time. And that's important in educating patients about recovery, speed of recovery, and it just sort of dictates how much therapy and the intensity of therapy that's necessary. But this patient really did quite well from moment one. And you can see here, his back pain was close to 100, down to 10 at 3 months. And then this is a great example of how you even start to come down from there. Now it's 6 for the back score, 6 for the right leg, and 7 for the left leg. And so again, just the trajectory of this is different than fusion. Sometimes in some patients, honestly, the recovery just takes longer, like a total knee replacement, in a sense where you have to really do the rehabilitation, but you continue to improve over time, which is something that I think is really exciting about this study. This is my next case here. This case is really a good example of kind of a standard patient, and a patient that's challenging to know what to do with in your office. This is a 49-year-old lady I've been treating for a while, a couple of years. She's a school teacher in the community, has kids, and she had a second recurrent herniation. The first herniation was treated by another surgeon, and then I saw her, and I did a microdiscectomy, revision microdiscectomy on her, and she did beautifully from it. for probably 6 to 9 months, and then had another recurrence. And you can see, even without the MRI again, that L5S1 level, how sort of collapsed it is from the prior trauma of the microdiscectomies, but also just the pathology there. Again, no spondy, but collapsed and just presented with significant radiculopathy. Again, just failing all conservative modalities. So here you can see her. And, to Alex's point, the carpentry, it can be challenging, just like when you convert from doing a lot of cervical fusions to cervical arthroplasties. You really got to be diligent, and there is some learning curve to that, but also a lot of slight imperfection can also be accepted well. This lady's done beautifully. She's got a little bit of roll on AP, nothing to speak of, nothing significant to speak of. And on the side view, you can see that the implant is lined up well, and really allowed her to get back to life a lot quicker. If we look at kind of her scores again, you see that majority of her pain was leg pain because it's a recurrent disc herniation, and we were able to keep her from having a fusion-based operation. She's only 49. Certainly that wouldn't be her last, and we're hoping that this is her last, or certainly putting it off for a long time. And you can see again just the resolution of those leg symptoms in particular, but also improvement of her back symptoms as well. And this is another woman that relatively young, motivated. She certainly had to do some physical therapy, but her recovery was relatively quick compared to some of the older folks that had maybe stiffer spines that required a little bit more rehabilitation to get moving. This is the last case that I'd like to present, and this is the ugly, and this is something that I certainly learned from, and I hope others can learn from it as well, and spend a little bit more time discussing it. So this is a patient. He's 51. Another guy in the community, has a blue collar job, and has a long history of L4-5 pathology. Had a pretty aggressive decompression done a number of years ago, and developed really severe recurrent central stenosis. And you can see also has some spondylolisthesis on the standing film and the seated lateral, but also a little bit of a lateral listhesis on the AP, and slight asymmetry coronally. It still fit within the parameters of the study, but was sort of on the edge in terms of having some asymmetry there. And so you can see it's just certainly a more complicated scenario and required more complicated carpentry for this. So this is this patient. So you can see x-ray is not quite so pretty. I think some critiques for this: probably could use one size up implant for this gentleman. I think that the center of rotation is probably a little bit posterior. You can see, like Alex had showed, that a lot of these with small spondylolisthesis will have a little bit of increase of that, and the implant will look a little bit proud, which is okay because of where the implant is positioned. And then it just settles there and becomes, stable. And that's what we saw in this patient. But the thing that really became the learning point here, this patient developed over time pretty significant right leg pain. And it was positional. When he came into my office, he was walking tilted to the left, because when he tilted to the right or was straight up and down, he had immediate right leg pain. And so obviously not ideal. And as part of that, did a pretty extensive workup, including a myelogram, which was really helpful to see. But without getting into too much details of the procedure, you really have to remove all of the lamina in this procedure. And Dr. Hodges and some others have really talked about this hidden zone. And what we mean by that is sort of, we all think about Camden's triangle, right? And it's a safe place to operate in the spine, and is a relatively static place. You have the exiting nerve root, you have the thecal sac, you have the pedicle below. But the reality is that overhanging lamina above, and even at the really bottom portion of that cranial pedicle, if that is removed, that nerve root will sort of float cranially, and it actually becomes a sort of dynamic space, which is why this implant works where it goes, and you don't get impingement of that exiting nerve root, and you just get a really significant neural decompression. Well, in this case, it was the perfect storm of the convexity of a little bit of coronal asymmetry, just someone who already had a relatively small foramen, and then me leaving a little bit, just the slightest amount of overhang of lamina, something that you would never think twice in a fusion. At least I wouldn't, and patients do just fine. And in this case, caused impingement. And so ultimately, I did take this patient back and did a revision laminectomy. after digging through the scar, it was a really quick operation. I just removed that little bit of overhanging lamina, maybe a whisper of that caudal aspect of that L4 pedicle. And you could really, you could see the nerve root. It was in clear, it was clearly free from any impingement from the implant or any kind of bony stenosis. And I'm thankful and happy to say the patient woke up and he sent me a video the next morning, his wife did, of him just walking like a normal human being again. And I just saw him actually back in the office and he was cleaning his gutters and had walked 5 miles. So he's extremely happy. He's doing so much better. And we're getting him back to work. So thankfully it was not implant related. It didn't require revision to fusion, but I did learn a lot from it. I think that just like the learning curve, again, for cervical arthroplasty, you got to really, in a way, tighten up some of the things you do from a carpentry perspective. And it sort of taught me a little bit about some anatomy that I thought I understood, but I think ultimately my understanding of it has evolved and thankfully led to a good outcome. This just shows the patient's scores. You can see that he did well initially and then developed that right leg pain between the 3 and 6 month mark, and then was revised in terms of his laminectomy. And I just saw him back in the office. He's having no leg pain at all, but I'm really anxious to see him in a few months for his formal 6-month follow-up.
Hi, I'm Dr. Anton Jorgensen, orthopedic spine surgeon in San Antonio. Thank you very much for the introductions, and thanks for the opportunity to be part of this fantastic project. I'm very excited about motion preservation in the lumbar spine. I have a large volume of patients who've had 1 and 2 level lumbar fusions. I remember one young woman in particular. She was a 15-year-old teenager, and she had a painful isthmic spondylolisthesis at L5-S1 level. And now 7 years later, she's in her early 20s. And, now she needs something done at L4, L5 level. So I really think that there is a lot more that we can do in spine surgery to make spine surgery better, to preserve motion. And in my view, I think as spine surgeons, we're sort of where the hip and knee replacement surgeons were 50 years ago. So I think that we're on the cusp of, some tremendous improvements in spine surgery. And I'm really honored to be a small part of it. I'd like to present 3 cases. The first case that I'm going to present is sort of a very challenging case where I'm at right now, where I feel that I can tackle really, really difficult cases and do motion preservation, even when disc spaces are very collapsed and even when there is a significant spondylolisthesis. So I'd like to present this first patient. This is a 64-year-old gentleman. And you can see from the lateral x-ray that there's a grade 1 spondylolisthesis. And you can see that there's a clearly spondylolysis at L4 as well. So this obviously, before 3 spine, this obviously would have been a single level lumbar fusion case. But now with motion preservation in 3 spine, we can actually restore motion, decompress, and preserve more function. So I'm going to go to the next slide here. I'm going to present a series of fluoroscopic images. And if you look at this close-up fluoroscopic view from surgery, and on this close-up fluoroscopic view intraoperatively, you can see that the disc space is collapsed. And you can see also that there's an anterior translation of L4. And because of that, the lip of the posterior superior corner of L5, there's no easy way to get into the disc space without going through the exiting nerve root. So I'm close to the end of my study period. I now have about 18 of these cases under my belt. The solution to this, the way to get a very good result and to get into the disc space is to take a burr, and with a burr, to burr 2 or 3 millimeters off of the superior aspect of the L5 pedicle, and with a burr to burr about 2 or 3 millimeters of the posterior superior corner of the L5 vertebral body. And by doing that, you then create an interval where you can easily place a paddle to get into the disc space, rotate the paddle slightly. And at that point, the disc space will open up, and then you can put in 5 millimeter, 6 millimeter, 7 millimeter distractors to get the disc space opened up quite nicely. And then, of course, when performing an osteotomy, one has to take down a significant portion of the posterior superior corner of the L5 vertebral body and the cephalad aspect of the L5 pedicle. And by doing such a pedicle vertebral body osteotomy, you're able to work your way into the disc space and achieve this final result where you've distracted the disc space very nicely. You've restored lordosis by performing a pedicle vertebral body osteotomy of the posterior superior portion of L5. And you can achieve a good reduction of the spondylolisthesis as well. And so I present the postoperative X-rays, the lateral views and the AP views, and the patient is, back in, well, the patient is doing extremely well. He's had complete relief of his claudication symptoms, and he's walking long distances every day, still in the postoperative recuperation period. This, I think, is a challenging case. So that's an example of sort of where I am right now. The second case that I'd like to present for you is sort of more of a typical bread and butter balanced back arthroplasty case. And so I'd like to present to you an L5-S1 case where the pelvic incidence is not excessive, where a large osteotomy is not required, and where it's very, very straightforward to get into the disc space. And you can see on this standing lateral X-ray that the patient has, some degenerative changes throughout the lumbar spine, but the osteophytes, stenosis, and degeneration are very, very severe at the L5-S1 level. Now, I'm going to present fluoroscopic images here, and you can see in this lateral fluoroscopic image that there is no spondylolisthesis at L5-S1 level, and that there is a gap between L5 and S1 through which you can insert, you can perform an annulotomy and insert a paddle and then distractors to sequentially dilate the disc space. And in this case, since the pelvic incidence was not excessive, and since there was no need to get a large osteotomy, you can do a 10 or a 15-degree pedicle vertebral body osteotomy, and then continue distracting. As you can see, we're distracting under fluoroscopy, and then you can slowly dilate the disc space, and then you can get a well-positioned balanced back arthroplasty implant in position. So this is sort of what I would consider kind of a bread and butter, typical balanced back arthroplasty case. There's no spondylolisthesis. You don't have to burr your own channel into the disc space. There's plenty of room between the exiting nerve root and the disc space to get the implant in. And there's plenty of room between the exiting nerve root and the traversing nerve root. And so this is what I consider to be sort of the bread and butter balanced back arthroplasty case, which, hopefully we'll be doing lots of these in the future. The results are very rewarding. This patient's done extremely well, and it's a straightforward case. The last case that I would like to present is sort of a case where I did have a complication, where I did learn something, and where there's some technical nuance that I'd like to share. And this sort of builds on Ben's case example. It does involve some stenosis of the exiting nerve root. I'm going to present the case of a 64-year-old woman. The patient is status post a prior microdiscectomy at the L5-S1 level. And you can see on this preoperative X-ray that the L5-S1 disc space is completely collapsed. So she had severe low back pain referable to L5-S1 level, and the CT scan and the MRI imaging studies showed loss of disc material and modic changes at L5-S1 level, and the remaining levels were actually in pretty good shape. So, I'm presenting now the fluoroscopic images, and you can see in this initial fluoroscopic image that, I was able to work my way into the disc space. I was able to slowly dilate the disc space. And then I placed trials, and then I placed my implants. And on first view, these implant positions, I think, look reasonable. You can see that there is the space between the upper implant and the caudal part of the L5 pedicle. There is a space there, but it's more narrow than other patients that I've done surgery on. And so initially, the patient woke up from surgery, and I was a hero. The patient loved me, the family loved me, everyone was very, very grateful. Well, starting about a week or so after surgery, she has severe, severe burning pain going down the right leg, and it's going down the right leg. And I asked her where it goes, and she says, doctor, it's going all the way down to my foot. And I asked her where in the foot it's going. And she says, well, it's going into my calf. And also I feel it really badly in the top of my foot and between my big toe and my second toe. So, at this point, she's describing some pretty classic L5 pain. And of course, I brought her back to clinic. I gave her Medrol dose pack. It wasn't effective. I brought her back to clinic. And you can see on this post-operative x-ray that it appears as if there may have been just 1 or 2 millimeters of anterior migration of L5 relative to the implant. And in addition, I would say there's maybe been 1 or 2 millimeters of settling of the L5 component into the L5 vertebral body. And so now that space between the bottom part of the L5 pedicle and the superior balance back implant, that space is narrowed. So I'm going to go to the next slide here. And on this next slide, which consists of a series of CT myelogram images, you can actually trace out and follow out the exiting L5 nerve root. And if you look at the contrast, and it's if you look closely, just below the L5 pedicle in the sagittal view, you can see some small amounts of contrast material. And if you scroll through the sagittal views, as I'm doing here, you can see that you're actually following out that exiting nerve root, the exiting L5 nerve root. So what I learned from this postoperative CT scan is 2 things. First of all, there was some settling and 1 or 2 millimeters of migration of the L5 vertebral body relative to that upper component. And so that gap between the implant and the caudal portion of the L5 pedicle, that gap closed up. But ultimately, I counseled her that with a bit more time, that her symptoms might resolve. And in fact, that's what's happened. With additional time, reassurance, additional gabapentin, and another Medrol dose pack, the L5 radiculitis resolved without requiring an additional surgery. So this, I think, was an important learning case for me. What I learned is that in these cases where there's not very much room below the L5 pedicle, that going forward, I'm going to do a formal pediculectomy. I will decompress and resect probably the caudal 30% or so of the pedicle to create more room in that neuroframe. And in this case, I kind of got lucky as the L5 vertebral body and the implant settled together, and as that space closed up, the exiting nerve root was shifted backwards, there was no active compression on that nerve root after that shift happened. And then with some additional time, her radiculitis did resolve. But for a few weeks, she had severe pain, and it was a very challenging thing to manage. So that's something that I've learned. It kind of relates to Dr. Ben Gettys' example. And this is where I'm at with the balance back arthroplasty. At this point, I think I can tackle a really challenging cases. So I do thank you for your time, and I'd be glad to take any questions or comments.
All right. Thanks very much. My name is Ahilan Siviganasan. I go by Siva. I feel very fortunate and blessed to be a part of this effort, both the IDE study and this masterclass session. I'm going to take a little bit of a different approach for the next few minutes, as opposed to discussing some cases from the experimental arm of the IDE study, given that we are just now enrolling patients into the fusion arm of the study. I'm going to speak a little bit more about some of the data that has accrued outside of the United States and what we can look forward to, at least as a glimpse in terms of the IDE data. So I'll give you a brief background about myself and why I might be in a good position to speak about some of this data. I had the good fortune of studying statistics at Rice University and obtaining a bachelor's degree in statistics. And then during medical school, I took a year off and went to Berkeley out in the Bay Area in California, and did a special year training in machine learning, artificial intelligence, and advanced data science. I then did my neurosurgical training at Vanderbilt and spent a lot of close time and training with Dr. Clint Devon, who is near and dear to many of us here as part of this effort. and then I did an orthopedic spine fellowship at the Hospital for Special Surgery. I'm now at Thomas Jefferson as an academic neurosurgeon focusing on spine surgery, motion preservation, and minimally invasive spine procedures. And I'd like to take you through some of the data that has been accrued as part of the MODIS implant procedures over the last many years in the Cayman Islands to give a sense of what we might expect long-term from the IDE study. Obviously, the actual results of the IDE study remain to be seen, but hopefully this will give us a little bit of a glimpse. So before I get into that data, I would like to mention that there's a long history of prospective outcomes data collection in the last 10 to 15 years in the United States as it pertains to spine surgery. And a few of us were fortunate enough to spend time at Vanderbilt, which was a leading institution in developing the protocols and designs for prospective outcomes registries. I had the good fortune of working with Dr. Clint Devon and others as part of Vanderbilt's outcomes registry and doing some advanced data science and predictive modeling along those lines. And then had the particular luck to be able to take part in the Quality and Outcomes Database and American Spine Registry, which are sort of national consortia that combine and pool data from multiple prospective outcomes registries at sites across the country. And so hopefully that background and experience will be relevant to any questions that anyone might have about the data we're going to show today. Before we dive into the data, one thing I'd like to mention is that anyone who has had a chance to take a look at the published manuscript that shows 1 year outcomes regarding patient-reported outcomes for the MODIS implant as compared to the TLIF operation may have noticed that essentially in that study, long-term 1 year outcomes were obtained for TLIF patients through the prospective outcomes registry at Vanderbilt, which sort of represented a historical retrospective control, if you will, for patients undergoing TLIFs. And that was compared against 1 year outcomes for patients that received the MODIS implant outside the United States and that were not part of this current IDE study. The question obviously remains, though, anytime you compare two cohorts of patients is, what are the potential confounders? Are there certain factors unique to TLIF patients that differentiate them from patients that might be interested in a MODIS implant? And could those potential confounders have something to do with any potential differences in long-term outcomes at the 1 year mark? And so a very established and validated technique for addressing this concern with these kinds of comparisons is something called propensity score matching. And obviously, I'm not going to get into the weeds of the mathematics behind it, but essentially what it does is it creates simulated or artificial subsets of patients in the control arm and the experimental arm. So in this case, for the 1 year study that has been published between the TLIF arm and the MODIS experimental arm, these sample subsets essentially are designed to match patients according to the various confounding factors that we think may be relevant to the 1 year outcome of interest. So say there's a concern, for example, that MODIS implant patients might be younger, and maybe that's why they have superior outcomes, or perhaps that they have fewer comorbidities, and maybe that's why they have better outcomes. So this propensity score matching is a way to essentially create mirror image cohorts across these two sets of patients, and to make an effort to adjust for any bias that otherwise might exist. So hopefully that helps when anyone is taking a look at that paper that's been published showing 1 year outcomes between TLIF and the MODIS implant. So what I'd like to do now is take a glimpse at long-term outcomes for patients that received the MODIS implant, the lumbar total joint replacement, outside of the United States preceding the current IDE study. So we have about 86 patients sort of in the initial cohort that received the total lumbar joint replacement. There were about 9 patients that ended up being excluded from this analysis and I'll briefly speak about some of the reasons for that. A couple patients had traumatic events such as falls that led to fractures in and near the implants that required some revisions. There were also some infections, some superficial, some deep, and polymicrobial that required a washout and conversion to fusion. And there were a couple episodes of some psychiatric mental health issues that sort of took patients on a completely different course. And so those patients were excluded, given that their long-term outcomes were sort of made murky by these other issues. And that leaves a final sample size of 77 patients. So that leaves about 77 patients in the final cohort. Before I actually get into the data, one thing I want to disclose or clarify is that by no means are we saying that the IDE data necessarily reflects in any quantitative way what we have seen in the long-term outcomes from the patients that underwent the MODIS procedure outside the United States. However, it is something that we can provide to give some idea of what we could expect. And of course, the real results of the IDE study will unfold in the coming months. So just to give you a sense of sort of who these patients are, the patients that underwent the lumbar total joint replacement preceding the IDE study in the United States had an age range from about 19 to 82, a BMI from about 19 to 40. And interestingly, quite a few of these patients had more than one level treated, and some of them were hybrid procedures where they were performed in the setting of a prior fusion. Patients had the surgery from L2-3 all the way down to L5-S1. And so you can see here that these were not cherry-picked patients that only had, L4-5 to be addressed and never had previous surgery, but really, ran the full gamut of complexity of degenerative lumbar spine surgery. So to give you a sense of the outcomes now, most people have probably heard of the ODI, or the Osteoplastry Disability Index, which is the validated patient-reported outcome that represents disability from lumbar spine pathology. It's a score that goes from 0 to 100, with 100 being maximum disability and 0 being zero disability. And so we see here that on average, the baseline preoperative ODI lumbar disability score was about 46, and that at the 4-year mark, the average score had dropped to 8, which is a very meaningful and dramatic improvement. And you can see here on the bar graph and on the table how those average ODI scores dropped over time from year to year. And we can say that the average percentage reduction in the ODI from year to year was about 77%. Obviously, when it comes to lumbar spine surgery, the big metric we all often care about is leg pain, the numeric leg pain score. Obviously, many of you are accustomed to seeing this as a 0 to 10 score, obviously with 10 being maximum pain. In this data here, we're not just looking at the amplitude of the pain, but we're also looking at the frequency of the pain over the course of a week. And so if you have 10 out of 10 pain, and you've experienced that 10 times over the course of a week, that actually gets you a score of 100. And then obviously if you have 0 pain, across 10 time points in a week, you have a score of 0. So that's the background to the 100 scoring system. Again, here we see that patients on average at baseline preoperatively had a score of 46, and then at the 4-year mark had an average score of 4, which is a very meaningful improvement. And that correlates with about an 80% year-on-year reduction in the leg pain. Similarly, for back pain, an average preoperative score of 52.3 that went down to 6.2 at the 4-year mark, with an average year-on-year percentage reduction of 83%. I'd like to now take you through a few sort of what we call composite scores. So a lot of times patients and even surgeons will say, what do I make of this? Okay, my ODI was a 60 before, and maybe it's a 30 now. What does that mean? Is that enough to constitute a successful surgery? How does that relate to the other metrics that we're measuring? So to that end, substantial clinical benefit is a validated definition, which essentially defines a threshold above which a patient has experienced a very meaningful benefit, not sort of the minimal benefit required to register as a change in satisfaction, but beyond that. And so we define, or as I should say, the literature defines a substantial clinical benefit as a 36.8% reduction in the ODI score as compared to baseline. And we can see here that year on year, on average, about 88% of patients achieved that substantial clinical benefit threshold with respect to the ODI score for lumbar disability. Another composite score, if you will, is the minimal symptom state. And what this does is it says, okay, what if a patient has a great improvement in leg pain, but their back pain gets worse and their ODI gets worse? Like, is that a success? Is it not a success? So the minimal symptom state really takes all these three sort of primary measures into account as a whole: the ODI, the back pain, and the leg pain improvement, and looks for less than 20 scores, less than or equal to 20 scores in all three. And so what we see here with the patient cohort is that year on year, about average of 74% of patients achieve that minimal symptom state, which is quite a good improvement. If you actually go into the actual year-by-year data, which you can see in the table on the bottom, about 75% had achieved that at the 1-year mark. That number dropped a little bit at the 2-year mark to about 70%. It's not hard to do that because it's a composite score. All it takes, for example, is for the back pain to go above 20 to say 22 or 23, and suddenly you're outside of that minimal symptom state because you need all three metrics to be under that threshold. And then at 3 years, about 65%. But then at the 4-year mark, very durable procedure, 86% of patients at the minimal symptom state. A term that many people may have heard of is the MCID, or the minimum clinically important difference. This is a sort of a more conservative definition as compared to the substantial clinical benefit score that we mentioned earlier. This is basically saying how much of an improvement does a patient need to achieve in a given patient-reported outcome for that to translate into a change in the satisfaction that that patient has for that surgery. And for the ODI, the latest literature suggests that we should be using a 30% reduction from baseline in the ODI score as a definition for this MCID. Previously, the literature supported discrete ODI improvement numbers, like say 18 points or 20 points or what have you. But what we realized over time is that there was what we call a goal line effect, that if you are at 20 points for your preoperative baseline, it's very hard to improve by, say, 18 points. But if you're at an 80 out of 100 at baseline, it's much easier to achieve that 18-point improvement. And so for that reason, we have switched to this percentage reduction. And as you can see here, the average percentage of patients that achieved this MCID score for ODI was about 90%. And you can see the year-on-year percentages at the bottom table. So I'll end with a slide where we essentially show you sort of head-to-head from the 1-year study that's been published, what some of these percentages look like for the total joint replacement Modis implant procedure versus the TLIF. So just from a bird's eye view, if you look at what percentage of patients at the 1-year postoperative mark achieved a substantial clinical benefit, it was 59% for the TLIF arm or the TLIF cohort from the Vanderbilt Prospective Outcomes Registry, as compared to 86.67% for the total joint replacement. And so these are, marked differences. And I will again, reiterate that, of course, this does not represent real-time data from the currently ongoing IDE study, but rather long-term data from the lumbar total joint replacement procedure performed outside the United States preceding the IDE study, as compared to historical fusion cohort drawn from the Vanderbilt Prospective Outcomes Registry. So I hope that gives everyone a sense of the numbers, a sense of the potential that we see in this procedure, seen through the lens of validated and established patient-reported outcomes, and not just 1 year data or 2 year data, but 4 year data. And so I'll just end by saying, you know, as a neurosurgeon, young in my career, I'm extremely excited by the prospect of what I see as really a step change and a paradigm shift in how we can address, lumbar spine problems and really set patients up for success in the long term and not be sort of trapped into the fusion paradigm that's been sort of the dominant paradigm over the last few decades. And so again, I'm very blessed and grateful to be a part of this effort, and thank you very much for your time.
Siva, that was a great summary of the statistics and really highlighted the outstanding data from the Caymans. And as you said, we don't know what our data is going to look like in this trial, but if it's similar to the Caymans data, then I think our patients are going to be very happy. I also want to thank Alex, Ben, and Anton for presenting their patients, and thank you for being so transparent, because this is what it's all about. Because we don't want to go into this thinking that everything's great. You know, like anything in spine surgery, we want happy patients, but we have to work for that. So thank you very much for the excellent work. And as I said when we started, you are the leaders in the world on total joint replacement for the lumbar spine. So we've taken a lot of important time, great time going through these cases. What I'd like to do is if we can take some questions from our audience. I'll address the questions to each of you. We'll start first with Alex. One of our viewers wants to know, what is the hardest part of the surgery for you?
For me, the hardest part early on and even still was always really getting the keel cuts lined up. When you put this implant in, you do the decompression, you do laminectomy as you would with a standard fusion procedure. But then as you're doing that osteotomy to make sure those end plates are going to line up perfectly, you make a keel cut into the superior part of the pedicle of the level below, and then you have to line that up perfectly with the level above, the keel cut made in the inferior end plate of the upper level. And they have a cutting guide or a tool that assists with that, but it's still a challenging part. You have to retract the exiting nerve root out of the way. In some cases, it's more low lying. In some cases, there's a smaller space there, as Anton and Ben indicated. So really making sure that decompression is done of that exiting root so that you can move it out of the way, visualize that it's out of the way, and then really visualize that keel cut to get those implants seated perfectly and converging nicely. That was probably the most challenging part of the operation for me.
And then the rest was all easy, right? Our next question goes to Ben. Ben, this is a question from one of our viewers in Los Angeles. He asks, how has doing lumbar joint replacement compared to doing cervical arthroplasty? Can you make that comparison for us?
It's a good question. I mean, there's a lot of similarity to it in the sense that, again, you have to be a little bit more precise with your carpentry, a little bit more broad with your decompression. I'd say probably even the lumbar spine is a little less forgiving than the cervical spine, I think, just because of the forces and the load that's seen there. But in a similar way, I mean, you up your game. I think even at my fusions now, I'm doing a little bit better than I did before, just with a little bit more thought to the exiting nerve root and a little bit more thought to the carpentry aspect of it. But it's certainly doable. And every rep that you get, just like anything, you get better and better. And if you're a good TLIF surgeon, it's certainly a good starting point for this procedure.
So this is a question I actually want to address to the three experts, since you've talked about doing more and more cases. What do each of you think the total number of cases is that you need to get to the learning curve so that you feel you know what you know? Well, let's start first with Alex.
To echo what Ben said, obviously you get better with each case, and I was a little bit sad to finish my 20th case, and now we have to wait for the next opportunity to do it, because I've just felt really around probably case 15 or so, really starting to hit my stride, get some really nice results on x-ray and learn a lot of these technical nuances. I definitely think as I do more of these into the future, I'll learn more and more with each one. But for me, probably, 10 to 15 is a good starting point to really wrap your head around doing these patients or these cases in live patients. Obviously, doing cadaver work before that is essential as well.
And I think that's important to point out. As I said, there were no training cases. You guys all spent time in the lab and had some great training, but it was it for case number one. Anton, how about you? How long did it take, do you think?
So I think my experience was a little bit different. Before I was doing the balance back arthroplasty, I did my standard TLIF was a bilateral TLIF. And I was doing bilateral TLIF, bilateral, dissection of the exiting traversing nerve roots and placing bilateral cages. And if you look at my TLIF x-rays look almost like the balanced back x-rays, except for the fact that, I've got cages and pedicle screws instead of a mobile implant. So I kind of stepped into the balanced back already doing sort of a similar surgery. And I feel like after about 5 or 6 cases, I was sort of like hitting my stride. But I think that's really because I've been doing bilateral TLIFs for years that happen to have the same approach and happen to look almost exactly the same as the balanced back cases. So it was a little bit of an easier adjustment for me, sort of because of my personal history.
Ben, do you want to put a number to your learning curve?
I think it's probably more similar to Alex, that 10 to 15 mark. But as with anything, you continue to learn, and really, as you push different pathology, there's so many pearls that are pathology specific as well. And so, and certainly to be a true expert would take even more than that. But I think you can do it safely and adequately and get good results, as we've seen in our own study arms, even with with the 10 or 15 cases.
Alex, let me ask you this next question. You've obviously trained on some big deformity cases. My question for you that is from the audience is, what percentage of your current one-level lumbar fusions do you think would be appropriate for the MODIS procedure?
My practice now is primarily degenerative, so single-level lumbar fusion patients, it would be a high percentage. I would estimate 85–90% of those who would otherwise have a single-level fusion would likely be eligible for this, barring severe bone quality problems. And that now that may be a little bit loaded because I don't do as many lumbar fusions as I used to. I do a lot of decompression surgery for what many might consider a fusion indication, minimally invasive over the top type decompression. So my fusion patients are generally more of a true classic fusion indication. But overall, over those numbers, I think probably 90% would be a good estimate.
This next question we'll pass on to Ben. And the question that's asked from our viewer is, even though each of you do mostly minimally invasive surgery, do you think that doing the open approach for total joint replacement has markedly changed your outcomes compared to doing minimally invasive fusion?
Yeah, I mean, I think, for me, I did my cohort at our surgery center. So it was all outpatient, same day surgery, no overnight stay. So I think that, with thoughtful surgery, good indications, and then, anesthesia, paraspinal blocks, the things that we do in an outpatient setting, I think these folks can go home, quickly and safely. And I've not seen any issues. Thankfully I had no wound issues or infection issues. So no, I've not seen any issues with the open type approach for this.
This next question comes from.
Do you mind if I jump in, Jeff?
Please go ahead.
One thing that's occurred to me, and I think a few of us have discussed, and maybe have even talked about with other surgeons who are maybe skeptical or intrigued but have some concerns, is that there's this notion that perhaps much of spine surgery, lumbar spine surgery, is moving to less and less invasive. And there may be people out there in the audience that are sort of thumbing through the technique guide for this procedure and saying, wow, this seems like, is this moving in the opposite direction? This is sort of a big open procedure with a lot of bony work and bilateral full radical facetectomies and this sort of thing. And I've heard these kind of comments from others. And I think what may be worth mentioning is how striking it is that whether it's Dr. Gettys or Dr. Salaticky, and I'm guessing Dr. Jorgensen too, the vast majority of these patients leaving the same day and being procedures being performed in the outpatient setting at ambulatory surgery centers. I mean, there are a lot of MIS TLIF surgeons whose patients are not leaving the same day. And so for anyone out there who is sort of skeptical or has questions about sort of the invasiveness of this procedure, I think the proof's in the pudding. I haven't started in the enrolling in the IDE arm, so my personal experience remains to be seen. But I have been very pleasantly surprised and encouraged by the quick discharge, ambulatory nature of these procedures, and I think that should put some of those questions to rest.
So, Siva, you must have been reading over my shoulder, because that was the next question from Texas. What's your most pleasant surprise when caring for patients with lumbar total joint replacement versus fusion? Siva, that was a great answer. Why don't each of the three of you answer that question, if you don't mind?
Sure, I'll jump in. Yeah, so I think the greatest advantage, I think, is the subtle differences in the motion preservation patients versus the fusion patients. The motion preservation patients notice differences in, for example, bending forward, movement. They notice the improvement in movement compared to the lumbar fusion patients. The lumbar fusion patients definitely realize that they're stiffer. They realize that they don't have as much motion. And, activities like, bending forward, tying their shoes, bending forwards and backwards. The lumbar fusion patients, from an activity standpoint, they know that they've been fused. So I think the subtle nuances and differences in function of the motion preservation patients, I think, has been very, very gratifying.
I'll add on to that what Anton said. I would echo that. One of the other things I've noticed in distinction from fusion patients is a fusion patient who, aside from the early post-operative pain, if you have a fusion patient who at 3 months is not doing well, many of those patients aren't going to continue to get better, and they may have another problem at hand that you have to address. Distinction with this is I have had patients in my cohort who at 3 months were having a hard time. Early onset, early pain resolution from the nerve decompression, but by 3 months, as they're starting to become more active, they have a rise in back pain. They feel a rise in almost hesitance to move. And rather than getting worse, those patients do get better with continued physical therapy, stretching, core strengthening, increasing their movement, not decreasing it, and not trying to avoid mobility. So pushing those patients through therapy, and by 6 months, they're much happier and pain-free is not something that I was used to seeing in most of my fusion patients.
Ben?
Yeah, I mean, I think to their points as well, I would agree with all that. And to Alex's point, just for, kind of transparency, I think the early recovery in some ways is more daunting with the joint replacement. Again, probably akin to like a total knee. You have to go to therapy, you have to increase motion, and the rest of the spine's got to catch up. And so some people, right away, we're doing excellent. We're sending me pictures of things, bending, twisting, doing things that I normally wouldn't even let my fusion patients do. And then there's some folks that were struggling at 3 months, 4 months. They were doing okay, but they weren't that home run you were looking for. And then it is really exciting to see them improve. And then you're getting the pictures of them doing the kind of stuff they want to do at the 6 month mark. And so I do think that trajectory, all this, is a little different for every person, is fun to watch unfold, and continued improvement is exciting.
Okay, one final question before we wrap things up. There are several folks in the audience who asked, I don't know if it's because I heard about machine learning or artificial intelligence, but Siva, can you tell us what you think the role is of AI in this procedure?
Let me just put that prompt into ChatGPT for a second, and I'll tell you what it spits out. Just kidding. I think one simple example of a AI application, which already has parallels and is currently available on the fusion side of things, is to say, hey, I've got a patient, here are my standing and seated slumped x-rays, and here's my CT scan. You send it out to software as a service on the cloud. It automatically does the alignment parameters and regional angular measurements, and then proposes a suggested post-operative sort of implant position and new alignment and degrees of osteotomy. You sort of approve that plan on your phone through an app. And then you get that sort of plan ready for you in the operating room. And then over time with, whether it's a navigation platform or robotics, you can actually see, as you're rasping or doing other bony work, to what degree you are achieving that desired preoperative plan in a way that sets the patient up for long-term success based on all the literature we have about alignment and things like that. So I think that's one use case of this. But I will say, it's occurred to me a lot, all the research horsepower that goes into alignment research with ISSG and everything else. A lot of that is so critical because fusion is such a unforgiving procedure when it comes to long-term alignment. That's the beautiful thing about motion, is that the body sort of finds its right set of dynamics. And so I think, AI research on alignment may actually be a little bit less useful because we've created, we're part of something here that sort of breaks the mold.
Great. I want to thank you all for your answers, for your time, and it's really been a privilege working with the world's experts on total joint replacement, and look forward to a future of good results for our patients.
That was, thank you, Dr. Goldstein, and the entire faculty. That was an outstanding discussion. And what a great course again. A great follow-up to our first course last February. And thank you, of course, to our sponsor, 3Spine, and most especially to you, our audience, who joined us tonight and provided so many great questions. I know we didn't get to all of them, so be sure a recording of the masterclass, by the way, will be on ryortho.com. But for any questions that were not answered, we are all, 3Spine is going to send everybody a thank you email. Be sure to respond to that with any questions you wanted to have answered tonight and couldn't get it done. And I know 3Spine will respond right away. So this ends our second masterclass on total joint replacement for the lumbar spine. Really outstanding. And to our audience and to our faculty, thank you so much. And all of you have a wonderful night. Thank you.